the QI journey for diabetes. So we're going to consider context and the problem, because we are here to support you. First of all, identify a problem and then work through that problem. So first of all, I'd like to acknowledge traditional custodians of the land on which we meet in the many different nations across the regions. We pay our respects to elders past, present and emerging as the holders of the memories, traditions, culture and spiritual well-being of First Nations people. We recognise their continuing connection to land, water, culture and community. We acknowledge any sorry business that may be affecting the communities as a whole, and in the spirit of reconciliation, partnership and mutual respect, we will continue to work together with Aboriginal and Torres Strait Islander peoples to shape a health system which better responds to the needs and aspirations of the community. And I'd like to acknowledge today that I come to you from the land of the Ngunnawal people. So this is an overview of the programme. So workshop 1, the slide decks and the resources that were provided in workshop 1 have been redistributed. So hopefully you've got a copy of those. And then we're moving into the coaching series. So we're going to have 2 coaching sessions. This one, as I mentioned, focusing on context and problem. The next one focusing on the aim statement. So what are you going to do, or what do you hope to do in relation to improving the care for people living with diabetes? So then we'll have another workshop, 2 more coaching rounds, another workshop, and then coaching rounds. So what we do today is come to you as a support system to support you implement change. And the purpose of that change is to work towards improved care for people with diabetes. So that's an overview of the programme. So with regards to the objectives for this session, so what we want to do is actually explain the approach we adopt to group coaching, give you the opportunities to actually experience that coaching activities that we'll be doing today, because your learnings will come from your participation in these sessions. So Paresh will take us through a facilitated process of learning and coaching. So we want to get your reflections. For those people who did attend workshop 1, we'd like some feedback in terms of what were your reflections, what did you learn in relation to workshop 1, how meaningful was it, and so forth. Then we want you at the end of this to be able to speak with confidence about your challenges. So we did ask you in preparation for this session to actually think about what the challenges were for diabetes care. So if some of you would be willing to offer those up, that would be really good. We want you to then consider the context and those factors that contribute towards those challenges. So we'll do a little bit of analysis there to get a feel for doing that factor analysis, considering both external and internal factors. And then we're going to come on to the important bit, which is around clearly defining your problem statement. So we'll take the challenges, do analysis, then clearly define the problem statement. The problem statement actually setting your agenda for improvement as you move forward. And then at the end, we'll do a little bit of reflection again, next steps, and think about what we'd like you to consider in advance of the next session. So this is our agenda. Reflections, we'll explain group coaching. We want you, on the back of this being a coaching session, to share with us what your goals are for today. We'll then explore your challenges, do a little bit of analysis, do problem statement, definitions, next steps, and close. So the highlighted there is the fact that Teresa's popped into the chat box 3 worksheets for your benefit. So one of them is the knowledge capture sheet. we'll come on to the analysis of context, and we'll come on to the problem statement. So at this point, just want to check in with everyone. If anyone got any questions on what we're proposing to do today before we kick off? Right on. I take silence unless someone pulls me up or raises a hand. I take silence to be confirmation that I can move on. So feel free to interject at any point. So, righty on then. The reflections. Paresh, do you want to just do a quick overview of what we discussed in the last workshop? And then maybe invite people to give some feedback.
Sure, thanks, Ange, and hi, everyone. Great to be with you again. For those who weren't at the last workshop, I'm Paresh. I'm a GP based in Canberra, and here today with the Prestantia team to really go through the coaching session. Great to be part of this, both as a facilitator, but I also see myself as a participant because we're doing a lot of work in our practice on diabetes at the moment as well. So it's learning from each other, which is fantastic. So one of the key things we went through, I think last time, was very much thinking about the what matters question, right? So we I think spent a fair bit of time, and we broke up into different groups and had the conversation around what matters, and we looked at it from different lenses. So we looked at it from the patient lens, the family member or carer's lens, and what matters. And I think in the documentation and shared for today, there's attachments to the whiteboard from there, and you know, my kind of sense of what came from that, not unsurprisingly, was that whole sense of people wanted to be about the whole person, not just about the condition. People wanted to be about prevention, whether that's prevention of the diabetes itself or prevention of the complications of the diabetes. They want it to be sort of individualized and personalized, and they really want the relational parts to be strong. So they don't want to feel judged, they don't want to feel misunderstood, they want to feel understood, they want to feel supported, they want to be respected, and feel have dignity in that sort of relationship. And access was a key part, whether it's access to a specialist, to allied health, to GPs, that sort of access to services was felt to be quite strong. Then we also looked at it from the lens, I think, of the care team, really. So what matters to the team members involved in the care of that person. And again, I think the sorts of narratives that came out from that conversation was being able to do a good job and being supported to do a good job, having the care processes working well was an important part, and that included, you know, things like having good data, being able to access the information about that patient, such as pathology, such as specialist referrals, or where they've been to see other people, and having time to look after them, and knowing what the pathways of care are. We also looked at it from the practice perspective, so where people might be sitting, the organization within which people might be sitting. So the practice, Aboriginal Medical Service, whatever service or unit it sits in, And I think there's some of the same things as what matters to team members were reflected. But in addition, and again, not unsurprising, there was some comments around what matters is having the workforce to be able to deliver the care and the service, and having the funding and the resourcing to be able to deliver the service to patients as well. And that, within that, I kind of include other things as well, like facilities and premises and good data and good infrastructure to do that. And recognizing that this is a bit of a team sport and the team's bigger than general practice and allied health and primary care. We also thought about what matters to other key stakeholders. So we looked at the LHD, for example, and the importance of preventable hospital admissions and presentations was important. The effectiveness of care and the efficiency of care across that whole pathway of care matters, and that was felt to be important. Certainly a sense from specialists around having strong primary care management was important to reduce pressures on specialist services. I think there's a general theme that ran through around equity and reducing barriers to care, and particularly care transitions as people might move from one part of the system to the other part of the system. I think that's me talking quite a bit, Ange. Was there were the key takeaways I had, particularly around that what matters conversation. Might just pause there.
Any feedback from anyone else? And what were the key takeaways, your light bulb moments, your what's, your learnings, your reflections on the last workshop where we considered what matters? Feel free to take yourself off mute and join in. Alternatively, add something in chat. Donna?
I think it's more of a comment that I think what matters and why people are here today is diabetes is I think it's an ongoing and developing science and treatment and management prevention in all of those areas. What matters is that we keep learning, and some of that is from one another. That we learn from the clients and the patients themselves, and we learn from the sectors and those involved in helping to support the whole person. So that's probably my biggest reflection.
Thanks, Donna. And that's the purpose of these sessions, to bring everyone together, because it is a complex environment we operate in, and it's dynamic. Things change. So, yeah. Anyone else got anything to volunteer in terms of reflections? We're capturing them on the whiteboard and we'll share these back with you, as we always do. Anyone else? Anything from the PHN side? Anyone from the PHN practice development team who would like to offer any reflections or learnings?
Hello, I do have something to say. I'm Tim Jones, GP from Mudgee.
Yeah.
I did do the reflection exercise, and we're trying to rebuild our chronic care clinic. And I think the problem is that each individual GP can measure the HbA1c, they can measure lipids, they can measure urine albumin creatinine ratio. That's fine, but no one is looking at things from an overall above perspective, as in the percentage of people in the chronic care clinic who attend appointments, who doesn't attend. No one's looking at have things improved over the last 6 or 12 months? And I feel that we need to get better at that, but we need to be better able to utilize our practice software to do things like this. And I think there's a lot of not knowing, and we're trying to establish this, but we need someone to become a champion of the chronic care clinic, and we just don't have that at the moment. And so I'd be very open to advice as to how we extract meaningful information from the practice software that is highly useful for the patient, the GPs, and the chronic care nurses. Yeah.
So multiple challenges in your practice. So we might ask you to hang on to that, Tim. Yeah. We'll come back to it. Anyone else like to offer anything? PHN, any reflections? Oh, Alison. Hi, Alison.
Hi there. Yeah, I just thought I might offer, so I'm probably in a bit of a slightly different or fortunate position that I get to support diabetes care across a number of GP practices. And so I've had a few conversations with some practice staff, and yeah, the story, the scenario that Tim puts forward is not uncommon, and practices are at varying levels of their journey with chronic disease support. And often what we can see is data is being collected and not entered in a meaningful way that it can be extracted, or as Tim mentioned, data is being collected and entered, but it's taking that next step and looking at the data and telling the story with it and identifying, I guess, where to make those, make the next step to improve quality in care and what to prioritise.
So as one of the key learnings from this then, based on my reflections of these issues that are cropping up, is actually improvement is a team-based sport in its own right. GP can't do it in isolation. So if you to drive improvement, you're going to need some additional supports, so some additional information and collateral to inform what you're going to do, why you're going to do it, where you're going to do it, and then the people to support you to do it. So would that be a fair reflection of me in terms of what you've just said?
I think so. And one of the big components being time, like someone actually having time to include that into part of their role at the practice.
Yeah. Yeah. Rightio. Well, thank you for that. Now I'm mindful of our time. I'm going to jump on that segue, Alison, and I'm off. So, are we okay if we push on? Anyone got any additional reflections? Feel free to drop them into the chat box and we'll add them to this compilation we're producing. So peer coaching, Paresh.
Thanks, Ange. So, these webinars in between the workshops are coaching sessions, and really, I guess when we're thinking about coaching sessions, I kind of think there's lots of parallels in terms of how we work with patients, and how we do coaching. So a lot of the coachings, I guess, is really about looking at what is it that you want to achieve, what's the goal, and really be sort of clear about that goal. And that could be a goal around the whole program, but it could be a goal around this coaching webinar. What would you like to achieve by the end of this coaching webinar? We all kind of live in a certain reality around that goal we want to achieve. So what is that reality? What is that context? What are the time pressures on us in terms of focusing on quality improvement for our people with diabetes. What are the constraints around the quality of data we can get from our systems? What are the financial consequences or financial constraints on the system? What does Medicare allow? What it doesn't it allow? What are the regulatory issues? What are the workforce issues? So we all kind of have a reality that we live in, within which we need to do that. And so whatever our goal is, I guess our goal's got to be contextualized around that reality, which is why I think we've kind of got the two elements of the objectives really around today's webinar, which is one is really understanding the problem, because if we understand the problem, we can translate that into perhaps a goal, but also understanding the context, because what you do in your practice will be very different to what I do in my practice, because the contexts are potentially very different. And so if we've got an understanding of those two things, we can then, through conversation and dialogue, generate some options. Those options then help us to think about a way forward and what we do next. And that way forward might be translated into a sort of tactical approach, and then an approach which kind of helps embed. So we talked about tactics and habits. So that kind of neatly builds into this acronym called growth, and so that's kind of the approach we take with coaching. So very much a relational approach, but weaving in and out of the goals, the reality, the options, the way forward, the tactics, and the habits. Now we're quite a large group today, and because we're a large group, it's we recognize and appreciate that we can't do that with everyone individual on a one-to-one basis, and that's where the idea of peer coaching also comes from. So the whole idea of peer coaching is to say, look, we can support each other. You don't need to be an expert. Many of you are clinicians on the call. You already got the coaching skills. You just use them with patients. How do you use them with colleagues to help us think through a different problem? And so the approach we're going to take today is a combination of sort of coaching and peer coaching, which is, we're going to ask for a volunteer, and don't all look down at this point. Even if you haven't got your cameras on, I can see you. So we're going to ask for a volunteer, and the idea of that is really to do a coach, a sort of fishbowl exercise around a coaching session. And then once we've done that, what we're going to do through the magic of Teams, one of the PHN or Prestantia team, I'm not sure who's going to magically put us into breakout groups of 2 or 3 people each in a breakout group. I think we're going to aim for, depends how many people we've got on the call, but we're going to aim for about 3 people.
We've got 10 on Paresh.
Okay.
Yeah.
Great. Okay. So yes, we might have three groups of 3 people, and 2 groups of 3 people, and one of 4 people. What we want to do in those breakout groups is really a bit of peer coaching. So having observed one coaching session as a fishbowl exercise, then within that group of 2 or 3 people or 4 people in that breakout is to do a bit of coaching with each other. So ask those questions of each other, ask what the goals are of each other, what's the reality in the different practices, to try and help that person generate a bunch of options to potentially explore and take forward. Does that make sense to people? Has anyone got any questions around the process? we'll take the silence as a cue to move on, Ange.
Okay. So this is building on the work you were asked to consider in between. So this is, as Paresh mentioned, to get a sense of your reality. So what are the issues or challenges you've identified in the provision of optimal diabetes care for people with diabetes from your practice perspective? So this is considering what your issues and challenges are. So, and Tim kindly kicked us off earlier by clearly articulating what the challenges were potentially in his practice. So, and just correct me if I'm wrong there, Tim. Yeah, what you mentioned was, and when I captured that was each GP can measure. So this is my reflection of what Tim came with, his issues and challenges. So each GP can measure the clinical indicators, but no one's looking at it from an overall perspective. So in terms of the system of care that's provided, because of part of that you picked up on practice attendance, well, who's actually measuring if these diabetic patients are actually turning up for their appointments and so forth. No one's extrapolating the data, and no one's reviewing the data to see how you're performing either from an experience or system perspective or from a clinical perspective. Clinical indicators, you mentioned the fact that the practice software systems and the data could be improved to help you to do that. And then you mentioned your challenge was not necessarily understanding how we build our CDM capability and what do we do next to help us on that journey. So that was an illustration of Tim. Tim, correct me if I'm wrong in terms of that capture of what you said.
I think that's spot on, Angelina, and I just think reiterating what I think was said earlier in the talk was, let's use data to tell a meaningful story that every clinician I work with deems to be highly useful. Yeah. And that they can get something out of it to say, right, well, we're moving in the right direction, not just with the individual patient, but with the overall diabetic cohort.
Yeah.
Yeah.
So it's the patient and the population perspective, the diabetic population perspective. There you go. So Paresh, how are we going to do this? We're doing it in plenary, in group, or in?
Yeah. So what I suggest, Ange, is we see if anyone's volunteering, and what I suggest is we do that sort of fishbowl exercise where we have a coaching conversation really around whoever's volunteered around what they're looking at, and then we break up into smaller groups after that. Now, I noticed Wendy's got her hand up. Wendy?
Are you keen, Wendy?
Yes, I'm always keen to volunteer.
Fantastic. Okay. So was the hand, Wendy, to volunteer, or was the hand to ask a question, or was it both?
To volunteer.
Great. Okay, fantastic. So we'll start that in a moment. Before we do, has anyone got any questions at all? No? Okay, we'll take that as a cue to move on. So can I ask Ange to maybe help do a bit of timekeeping?
Yep.
So how long would we have for a coaching conversation with Wendy? 15 minutes, is that?
Yeah,
enough,
let's keep it to 10, given the rest of the agenda. Yeah.
Right. So if you can give us, when we've got 2 minutes left, give us a little bit of a heads up.
Yeah.
Yeah. Okay. And what I'm going to do, Wendy, is I'm going to see if I can. Okay, that's great. I've got lots, everyone's images on the thing, and nice thing about the technology is I can pin you so I can see you and not the other stuff. Can you see me and hear me okay, Wendy? All right. So, Wendy, we've got about 10 minutes. What would you, in the 10-minute coaching conversation we have, what would help you? What would you like to achieve in the 10 minutes?
Having some ideas on how to encourage patients to actually attend appointments with allied health professionals at our service.
Okay, all right. So we'll have an exploration around patients attending this allied health appointments.
Mm.
Can I infer from that, Wendy, that there's an issue around patients attending those appointments? And what does that issue look like for you? What does it feel like?
So I work in an Aboriginal community controlled health organisation. We have GPs, we have, I'm a dietitian, I'm here full time. We have diabetes educator, podiatrists, access to endocrinologists via telehealth usually. Patients will attend to have their toenails cut and see the podiatrist, see the GP, but getting them to see diabetes educator and dietitian is very difficult. There's a lot of time spent trying to phone people, write letters, and then even if they do make an appointment, they may not attend. We also have the luxury of long appointment times, and we can do a lot of the care coordination and chasing up things for the doctors. But the problem is we can't get the patients to come to see us.
Okay, all right. So it sounds like it feels very much like, those appointments, they don't attend. Now tell me, Wendy, is it that they don't attend? So do they have the appointment booked and they say yes to the booking, but then don't come? Or is it that they won't book at all?
Sometimes. A lot of it is they don't book.
Yeah.
But then even if they do book, they may not attend. And we provide transport, free transport.
Okay.
And we try and make it quite accessible. But there's a lot of reasons, I guess, why they don't attend, but it makes it hard to provide diabetes care.
Can you tell me a bit more about what those reasons might be? So it sounds like you've explored some and even maybe put in solutions for some, but what are some of those reasons?
Most of our clients are, I guess, low socioeconomic background.
Mm-hmm.
Self-care in terms of health is not one of the greatest priorities. There's generational trauma for a lot of people. There's regular funerals. They might have lots of other things that they see as a higher priority than their health.
Mm-hmm.
Or that and trying to work in a prevention focus is perhaps not their biggest goal, but they're more about now and tomorrow rather than what might happen later on.
Okay. Anything else? Any other barriers?
There could be a little bit about who works at the service, but we try to offer people who are members of community as well as non-community members, as well as we have Aboriginal and non-Aboriginal descent staff. I guess for a lot of them, it's like other things are more important. They're happy to get a script or see a doctor if they're sick, but to come and talk to somebody about what they might do to change their diet or their exercise levels, they're not that keen on quit smoking. They would rather know where to get the cheap tobacco.
Yeah.
And I guess there's lots of issues because you can talk about things like diet change, but some people have to pay somebody privately to get a ride into the local supermarket. So no limited transport for that. Some are walking a lot anyway because they don't have a car or a license. There's AOD issues, mental health issues, domestic violence issues. Not everyone has functional phones as a reminder about appointment, to receive appointment reminders. And appointment cards get lost.
So lots and lots of reasons, and some of those reasons are, you're beginning to go into some of the social determinants of health as well, aren't you? That
Yes, yeah.
Do you have a sense from the data you have around the group that don't attend? So the group which are hard to reach for whatever reason. Do you have a sense of who that group is, and what are the different reasons for that group, as to why they don't attend? So I guess I'm asking around, has there been any exploration at any stage around diagnostics to understand the cohort who are hard to reach, and then understand the reasons why they might be hard to reach?
I don't think anything specific's been done. It's probably more just observations of working here.
Okay. And do you have a sense of, to what extent in addressing this issue, in addressing this problem, has there been involvement of, the very people we're trying to solve the problem for? So, the people that are hard to reach, have they been involved in helping with the solution, or to help understand the reasons for it?
Some have been, and it's not their priority. And that they have other health conditions that are impacting on them, and that's more important for them to address.
And have they been, when you say some have been involved, what's the process been of involving them? Has it been at that one-to-one clinician level, like or has it been a more system improvement type of approach to say, hey guys, we're trying to look at a problem here. Can you help us understand what we can do to help improve it? Has it been that sort of system improvement approach?
No, it's been more, I guess, talking with people like on the street, at their home, at community events or group, but not a systems approach. Nothing sort of going in with a formal plan or anything. It's just ad hoc asking people.
So thinking about, you've identified a whole range of potential reasons for it, including the social determinants. Some of those things are going to be within the influence, so you can do something about maybe some of those. Some of those things are totally outside, your scope of influence.
Yeah.
Do you have a sense of next steps to try and not solve the problem, but to try and understand the problem more, or to address the problem? What might be the next steps?
It's probably consulting wider with the community and finding about what's, I guess, preventing them from coming, or what might help them to come to appointments. I'm unsure otherwise.
How might you go about doing that, if that's if you say that's the next step? How might you go about doing that?
Well, if I had buckets of money, I'd put on a feed and offer them some money, and then they would come.
Yeah.
But otherwise, it's probably a matter of going to people's homes, or just talking with them when they're here in a group situation, or seeking just opportunities, yeah.
And how feasible might something like that be, to do something like that?
With some people, we have the ability to do that because we can easily do home visits.
Okay.
And we have time. We have
Yeah.
the luxury of time.
Yeah.
I guess part of it is coming up with an approach to do it and some the questions to ask in a way that's not
Yeah.
confronting and not seem to be judging people, and
Yeah.
then what do we do with the information we get?
Yeah. And would some of these people, you know, who you said you could do this with on the home visits and things, would some of these people be the very people who are hard to reach with the other things, like the dietitian or the exercise physiologist or the diabetes educator?
Yes, they are. Yeah. Yeah.
All right. So we'd be hearing the voices of the very people we're trying to reach.
Yes. Yeah.
Yeah. Okay. All right. How do you feel about pursuing that option?
Well, I feel it's an option that I need to find a way to do because
Okay.
it arises with lots of things. For example, a patient wanting surgery to remove a lump on their head that is growing. Couldn't find them, or they didn't answer their door yesterday, even though they're complaining about the pain. And as a result, they missed out on a surgery brought up early, and now it's delayed. And then their issues associated with that then affects their diabetes.
Yeah.
And that's just one person. So I would be very keen to think about how I can go about trying to improve, I guess, patients' access, if they want it, to our services, so that we can try and support them better and meet their needs.
Yeah. Wendy, just a little sidebar. Have you come across something called the Model for Improvement at all, or
No.
PDSA cycles? Have you come across?
Oh, PDSA cycle maybe, but I'm not sure. It's not something I'm
Okay.
very familiar with.
All right. Okay. No, thanks for that, Wendy. I'm mindful we're probably coming close to the 10 minutes we had for this coaching conversation.
Yep.
One of the thoughts that was going through my mind, Wendy, is it sounds like we've got potentially a really great idea to explore and take forward. The reason I asked the question about whether you've come across the PDSA or Plan, Do, Study, Act cycle,
Yes.
you know, the whole idea of doing a PDSA cycle is not to go all out with an idea and say this is what we're going to do. The whole concept behind it is to say we've got an idea, let's test this out in a really small way to see if it's going to work.
Yeah.
And I'm almost wondering whether using that PDSA approach might be a good way of testing out this idea of going to people and doing home visits and exploring their reasons perhaps for not coming to appointments or not attending appointments, and maybe that might help generate solutions sort of further along the line. If I was to perhaps give you a bit of information on PDSAs, do you think our next coaching conversation we could think about how we might be able to help take this forward?
Yes, thank you. Yeah.
Okay, yeah, not a problem. Was there anything else, Wendy, before we wrap up?
No, because the main thing is we've got to get people in the door to see us.
Okay.
And then we can help with the care. Yeah, thank you.
Great. All right. Thank you. So firstly, thank you so much for volunteering. We will time out of the coaching conversation at this point. I'm going to hand over to Ange to sort of take us through a bit of a debrief from the coaching conversation, and then perhaps break up into smaller groups after that. Ange?
Yeah, let me just share what I captured. So I've got something to work with. Oh yes, so a quick debrief. Where did Paresh start in relation to that coaching session? So we started by asking Wendy to clarify what the issues are. So, but then also to understand the context and how that issue, and sorry, this is how my brain works. So how that issue was experienced within the general practice. So when they explain things like there's a lot of time chasing people, can't get people into the practice to come and see allied health. For those who don't come in, a lot of them don't actually book, but there's another cohort who do book and then they don't attend. So that was to get a feel for the issue. So what is your problem? So that you're faced with. And then there was that exploration in terms of, so think about the problem. So what do you think sits behind that problem? So that's about understanding the context for the practice, but then the context for the patient, because this was a very patient-focused challenge. So if you think about exploring the why in the context, there's a lot of social factors there to do with the community. So there's that trauma and trauma-informed care. There's literacy levels, which create challenges, and therefore there's a potential lack of understanding in terms of why that allied health component of care is important. From a social perspective and a person-centered care perspective, actually this might not be their biggest challenge. They've got other competing pressures on a day-to-day basis. So they might prioritise some things over the others, like the scripts, over an appointment with a dietitian. And all of those infrastructure community-based challenges like access to shops, to food, healthy foods and things like that. But then the technical challenge you identified then from a contextual point of view. Sorry, let me go back to that. Have I stopped sharing? Or
Yes,
has
you
mine?
have.
Yeah. So from a technical point of view, there was the challenge of the fact that some of these people don't have access to mobile phones. So if you're going to send an appointment via mobile phone, so context is important. And one of the external factors we consider there is both the economic and the social context within which these patients operate. So it's really important to understand the context. But then exploring these hard to reach communities. So again, getting a sense of the reality. So think about that growth approach that Paresh adopted. And thinking about that hard to reach community. Yeah, there's specific challenges there, because what you'd identified, Wendy, is two different cohorts of people. The end result is neither of them are engaging. So yeah, so that's that understanding. So Paresh asked you to explore, and one of the opportunities that you could do is to do the engagement with the consumers and invite their feedback. So, and you mentioned there it was consideration of what the good questions would be that you would want to ask of these consumers to get a better and more in-depth understanding of what their key challenges are and why people are not likely to turn up to allied health appointments. So that was the opportunities. Paresh did a nice session to consolidate that, fed back to you, is this what I've heard? Is this correct? Would you be happy to take a next step? Well, in terms of the W of the growth, which is the way forward, is around understanding the next steps. And this is where you wanted to explore the problem with consumers. So, and talked about how you would do that. So think about the tactics and the habits and the how. What questions would you ask? And then Paresh stopped and ask you again in terms of, would you be confident in doing that? To which you said yes. So that's the way forward. Next steps, locking that in. And then in terms of the how to do that, Paresh said he'd send you some information on MFI, and would send that information through to you to help you pull together that activity and do that small scale test of change. So Model for Improvement PDSA is about keeping it small, learning from those small actions that you take before, in this respect, you come up with a solution. So this PDSA is about, are your questions right? Are you getting the feedback you need to then inform the next stage of your improvement activity? So Paresh, here's the growth. What's your goal? Well, first of all, what's the reality? What's the issue of challenge? What's the goal? What do you want to try and achieve? What are the opportunities for you to do that? How do you think you could do that? What's your way forward? Are you happy to take that next step? And then in doing that, how do you integrate the PDSA? So small steps. That a fair reflection, Paresh?
Great, thanks, Ange. Wendy, how did that feel as a process?
I'm very comfortable. It flowed. It's hard not to go off on tangents. But it was useful. Thank you. Yeah.
Yeah, great. So what we'd like to suggest is that everyone has a chance to have one of those coaching conversations. So in terms of time, we've got another 30 minutes. Is that right, Ange?
Yeah.
Yeah. So what we're going to magically do with the team is to split you into into some breakout rooms. Now I'm being a bit adaptive here, team, so totally apologize for having set you up in, asked you to do one thing earlier. I'm gonna ask you to do something a little bit different. So can we do pairs? Can we do breakout rooms? So we've got each of our participants going into a breakout room in pairs, and then as the PHN team, you can go in as an observer if they feel comfortable with that. Would that be okay? Is that manageable?
I have allocated 3 rooms, but which have got 3 participants then between Ange, yourself, Tamika, and PHN in them. So it works out roughly 5 participants each.
Okay, all right.
Do you want me to break that down lower to 2?
Can we have 2 participants in the room? I'm just being adaptive, and my rationale for being adaptive is I was thinking we've probably got about 20 minutes, and if we've got 2 participants, then each participant can have 10 minutes, being the coachee, and the other participant being the coach, and then flipping that after 10 minutes. So that gives everyone an opportunity to have a bit of a coaching conversation as a coach and a coachee.
Paresh, just give me 2 seconds.
No, you're all good. Thank you for making it happen.
So Paresh, that just gives us 5 minutes at the end to focus on problem statement.
Yeah. And as Therese is working out the coaching sessions for us, and splitting us into those groups, I guess, one of the things I would suggest is when you're having those coaching conversations, think about the problem. So coming back to what Ange said, it only gives us 5 minutes for the problem statement. The natural progression from what we've been talking about is to move to a position where we can really understand the problem we're trying to solve. And so if you frame the coaching conversations maybe around the problem, we can have the debrief in the last 5 minutes is really around that problem statement. Does that work, Ange?
Yeah, we'll make it work. Yeah.
Great.
So just while Teresa's setting that up, just a reminder, what's the issue of challenge? What's the reality or the context within which you operate? What are the opportunities and potential ways forward?
Let me see if this works. I'll open them all up now.
Fabulous.
Tamika, can you hear me?
Yeah, I actually had to leave. I left.
Yeah, I was trying to work out how to do it, and I had to go back in and go close rooms.
Oh, that's okay. I left and came back, and I'm like, all right, we're all back. It's fine.
So I have to apologise, everyone. I don't know who went into what rooms, and I was in a room. We just pulled one person on their own with poor Sally.
Not to worry. PDSA next time, please. Rightio. So yes, sorry, we were mid-sentence, but Donna, Alison, did you get the gist of what I was saying?
Yes,
Yes, thank you.
thanks.
Fresh one note.
Owen.
Next time we do that, there's only 4 of you guys. Can
Three of
only have
us.
4 break. No, Sue Ellen, Tamika, Ange, Paresh.
Joellen, supernumerary, 3 of us.
Oh, so there's only 3 breakout rooms going forward. That's all I'm saying.
Oh, you did well, Therese.
I know then.
It's all part of the learning curve. It's all good. Shall we, just mindful of time, so we've got 5-6 minutes. Ange, did you want to take things forward, or?
No, just some feedback on stepping through goal, reality, opportunities, way forward. I must admit, Donna and Alison, I did push through that. What were your reflections on that as a process? Very briefly, we'll take a couple of feedbacks and then we'll move to problem statements.
I think that process was really, helpful, and I think it is. It's always questions what you assume to what is reality. So I think that's always it's good to check in, and it helps with that sort of part of the diagnostic process. So yeah.
Yeah, great. And did it help you look at things from a different perspective?
Absolutely.
Yeah.
Yeah, I think just that questioning what you know about a scenario, and then questioning why do you know that, and is it assumed, or is it something that you've been provided information about, really highlights what Donna was saying about that, understanding your reality and being able to look at it and opportunities that come from that.
Yeah. Yeah, great. Any other group in terms of that process? Understanding the reality so you can better sort of work out what your potential problems are on the way forward, opportunities for moving forward. Alison? Got your hand up?
Yes, yeah. So in our group, Ange, I was talking to Lynn and Jennifer, and reality was that some sessions they asked the patient, what is the likelihood 1 to 10 of you attending an appointment with a dietitian or a diabetic educator as a follow-up, just to gauge the patient's level of commitment to health. Lynn or Jennifer, if I haven't said that correctly, please jump in. But I thought, well, to me that seemed to, you could get if the patient says a 2 or a 10, it's a good way to know of their commitment to their care.
And that's a point in time.
Mm.
Yeah. Anyone else like to add? I've got one more point to make before we move on. Tamika?
I think, Tim, correct me if I'm wrong here, we were just talking about his problem and issue, and I think with the reality really was around that it's very anecdotal, the data, and so understanding that data is really important, so that moving forward you can take further steps. Tim, I hope I've summarised that all up pretty right. Yep.
Yeah, that's right. Yeah, absolutely. Yep.
Fresh, can you build on that in terms of the data? Because we often say that we need the data to create a baseline to undertake quality improvement, but I'd like your perspective on whether or not we need all like a comprehensive data set before we can do anything.
Yeah, no, so my kind of take on this is we do need data. We need data. We need data to help inform what we're doing, but we don't need perfect data. It needs to be just good enough. And because otherwise we're never going to get anywhere, right? Because we're never going to have perfect data. And the other thing I would also say is data is not just numbers, it's also stories. So that mix of qualitative information, the patient stories we have, how staff are feeling, what are they noticing, I think it's all just as valid data as the percentage of people who had a HbA1c measured in the last 12 months. You know, it's bringing that quantitative and qualitative data together. I think it comes down to what's the purpose of the data, and what do we need that data for? Often when we thinking about it in quality improvement terms, we often ask those questions, what are we trying to achieve? How will we know a change is an improvement? And what changes can we make? That kind of implies, that second question, how will we know a change is an improvement, kind of implies that we want some sort of quantitative data that's going to tell us that we're tracking and we're improving. And we absolutely do. But I think at this early stage, we sometimes want data to help us understand the problem, because, the first step in any quality improvement, I think, is what's the problem we're trying to solve? And we've got to really understand that problem. We want to understand who that's a problem for, how often is it a problem, why is it a problem, what are all the different reasons that creates that as a problem, all those different reasons that contribute to the problem. Do we know the proportion of times those reasons contribute to the problem? Because all of that will help us understand and shape the problem to then translate it into something achievable, a direction of travel that's achievable. So, quality improvement, I guess, starts for me with really understanding the problem, getting a really, really nuanced understanding of the problem. Because once we've done that, we can then convert that into a smart aim. And then we can start to think about the changes that will help us get to that smart aim. And in our little breakout session, I was just telling a story of a few years ago. I was doing some leadership development work with a couple of pairs of people in New Zealand. And actually our conversation, Wendy, reminded me of this, because one of those pairs was a clinician and a consumer pair. The clinician was a dietitian. The consumer was a Maori person with diabetes, and the problem they were initially trying to solve was very similar. It's like, how do we engage the Maori population in attending appointments, etc. And it was really interesting where we ended up when we kept digesting the problem and trying to understand it and get to the data. was was an aim and then a solution, which was around building a community garden for a particular community. And the dietitian was going to go in there on a regular basis, support the building of this community garden, and in doing so was having lots of conversations around healthy eating, which would I have predicted at the beginning of the quality improvement project? Not at all. Wouldn't have a hope in hell of having made that prediction, but it was trusting the process and going through the process that kind of ended up with that solution.
Right on. I'm mindful of time, everyone. So we're at time. So just in terms of reviewing what we've done, so you've utilised that growth approach to have a conversation in terms of what's your reality, what are the issues and challenges you're faced with. So what's the context within which you operate? So some of that context, there's a tool there in the Dropbox in the chat there that says actually there's a number of external and internal factors that contribute towards a problem. So by understanding, articulating them, asking other people what their perspectives are, looking at the hard data as well as the soft data and the feedback to understand the context and the issues and challenges, and then think about opportunities for way forward and small steps of change. So that's what we've discussed today. So one of the things we want to ask you to do is building on that learning, and we'd like you to go away and further explore your problems or problem. Identify one problem, because there was multiple problems popping up in conversations. Identify one problem and then craft a robust problem statement. So there's a worksheet available in the chat box again. So who's it affecting? What's the problem? Why is it important? How does it affect key stakeholders? What kind of data do you have? Do you not have, but would like? What would potentially fix or resolve the problem? So opportunities for the way forward, and then craft a problem statement. And in the next session, 2 weeks' time, what we're going to do is we're going to road test your problem statement to make sure they're robust. And then we're going to use those problem statements to define an aim for quality improvement. So it gives you something tangible to work towards on QI that's relevant to you and your patients in your practice. So does that make sense, everyone? Yeah. I know that. Any questions before we head off? Oh, everyone confident they can do that between now and then? Yeah.
Ange, can I just confirm, has everyone got the invitation for the next fortnightly meeting?
Yes, thanks, Therese. It's Linny Lamble here, and I told you that I didn't have any, and that all I did was flick them all through and didn't look at what they were. So thank you.
Not a problem.
I have to be honest.
I know. All good.
Thanks, everyone.
Good.
Bye, everyone.
See you
Thank
then.
you.
Thank you. Bye. Bye.